distinguished guest. Hello, everybody, and welcome to Intersections of Gender's Research Friday series. My name is Nat Hurley. I'm the Associate Director for IG, as well as an Associate Professor in the Department of English and Film Studies, and the Director of Media and Technology Studies in the Faculty of Arts. Thank you for coming out today for this presentation from Dr. Colleen Norris. Before I introduce Dr. Norris formally, I want to recognize, as we always do, the conditions of possibility for our work here at the U of A, which is located on Treaty 6 territory and the lands of the Métis Nation Region 4. We work and live on the traditional lands of the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many other First Nations. Like all our institutions, the U of A continues to be shaped by the forces of colonialism to the benefit primarily of white settlers. I consider myself to be an implicated subject on these lands who recognizes that the work of being in good relation to my Indigenous colleagues, community staff members, and students is very much ongoing. I'd also like to say a brief thing about Research Fridays. We imagine this space as a venue for you, our community, to promote your research and thinking, or even just host a conversation in these lunch hour bite-sized events. So if you have works in progress, if you published a book recently, if you presented a conference paper, have a poster, anything you'd like to do, if you just want to get together with some people and read something together and talk about it, we'd love to hear from you. And this space is for you to do that. We just ask that everybody make space and time for there to be some conversation. We are open to all kinds of formats and styles. So without further ado, I do want to move directly to our speaker today, Dr. Colleen Norris, and I'm not going to read her detailed bio here only because she has a lot to share with us today, and she and I discussed in advance that I would take the time that I would otherwise spend outlining her enormous accomplishments. I'm just going to skip to one key detail that she has presented extensively and has over 300 publications in the areas of sex and gender difference in cardiovascular treatment and outcomes in women's heart health. So we have a lot to learn from her today, and I very much look forward to her presentation. And I'm going to turn it over directly to her right now. Thank you so much, Dr. Norris, for joining us today.
Thank you so much for the opportunity to do this. I'm just going to share my screen. And I gather you can see that. Okay, I'm from a discipline where we do presentations this way, and I feel so much more comfortable, and I really thank you for the opportunity of presenting. I'm going to hide my face if I can, because there. For presenting today, or rather sharing some of my thoughts on trying to move the dial on women's heart health. I do also want to do a land acknowledgement and mention that in her book, Braiding Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teaching of Plants, Dr. Robin Wall-Kilmer reflects on the meaning of land to Indigenous people and writes, in the settler's mind, land was property, real estate, capital, or natural resources. But to our people, it was everything. Identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the source of what sustained us. Our lands were where our responsibility to the world was enacted, sacred ground. It belonged to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings people took with them when they were forced from their ancient homelands to a new place. Therefore, I would like to begin by acknowledging the Indigenous people of the lands that we're on today. While we meet on a virtual platform, I'd like to take a moment to acknowledge the importance of the lands that we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and improving our own understanding, my understanding of local Indigenous people and their cultures. So from coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home. I have very selfish objectives for presenting here today. I had the good fortune of presenting last fall to a master's students in gender studies program, which was actually a very daunting prospect at first, but ended up being one of the most enjoyable academic experiences I've had in a really long time. I was there to speak about women's heart health and the journey I've taken to get to where we are today. So who doesn't like talking about their research? But more importantly, it was the first time in a long time that I sat back and said, women's heart disease deaths are on the rise. Even with all that we've done, women are less aware of their risk, and their lived experiences are still reporting that clinicians are failing to recognize their concerns. Not only did that presentation allow me to go back to the literature that was really out of my arena. I'm an epidemiologist, and because of COVID, we no longer actually need to clear up that we don't study skin. But as you probably come to realize, we're basically bean counters. But the questions and comments from this engaged group of young, thoughtful participants really got me thinking and reading about how to move forward. So I got asked to present again, and I jumped at the chance to get this to help me move forward through Research Fridays. So what's going on in women's heart health? Well, the impact of heart disease on women has traditionally been underappreciated. As a result, when people think of heart disease, they have an image of a man clutching his chest in pain. But did you know that cardiovascular disease is the #1 killer of women worldwide? Every 20 minutes, a woman in Canada dies from heart disease. It's the leading cause of premature death. And when asked what their biggest health threat is, most women will say breast cancer. But the reality is 3 times as many women die from heart disease as breast cancer. Heart disease rates are increasing in younger women under 55 years of age, and mostly due to a variety of risk factors and health behaviors. 1/3 of women with heart disease referred to their condition as an event or an incident, after which they resumed their pre-diagnosis lifestyle. So there's a problem because heart disease is a lifelong condition. There has been lots of evidence of sex disparities in the last 10 years, and the risk of heart disease is often underestimated, with notable differences in the presentation, the treatment, and outcomes for heart disease in women. And this is actually due to a lack of public and professional awareness of women's coronary risks, knowledge gaps regarding women's symptoms, presentation, optimal screening, and then the sex disparities that contribute to adverse coronary outcomes for women. So women are understudied, underdiagnosed, undertreated, which lead to multiple sex disparities. I've been involved in women's heart health for some time, and having thought that we were getting our message out there, but I was mistaken. This landmark paper just presented through the American Heart Association on the 10-year difference in women's awareness made me quite sad, actually. They concluded that awareness in heart disease in the long term, the cause of death among women declined. Actually, the awareness declined from 2009 to 2019, particularly among Hispanic, non-Hispanic, and Black women and younger women in whom primary prevention really might be effective. An urgent redoubling of efforts is required. And we need efforts by organizations interested in women's heart health. So in fact, we're using papers like this one published along with our papers from women with lived experience to inform Wear Red Canada Day. And I'll talk more about that later. Some of you might have heard these statistics, but they bear repeating. In Alberta, 300 women a year went to an emergency department with chest pain or discomfort or heart health issues and were discharged home, only to return within 30 days having suffered a myocardial infarction or a heart attack. 300 women a year. This is something that we have to change. As an epidemiologist, I started to create a cohort of data on these women, trying to understand their clinical picture in the emergency room during their admission. Is there something about this cohort that we might help identify red flags that we can report to the people taking care of them? I also started working with a brilliant Masters of Nursing student, Christopher Picard, who was looking at the narrative of these women in the ER. What language, what words are they using when they describe their coronary event? But I also started thinking about those clinicians taking care of these women. How do we understand what is their experience of their encounter in the ER? My research and Google scholaring through the sex and gender intersectional literature brought me to an article by Hall, Galinsky, and Phillips, who noted in their manuscript, Mosaic, a model of stereotyping through associated and intersectional categories, that demographic characteristics are a key source of bias in evaluations. Furthermore, they write that employers, this is in the management science literature, have started to acknowledge that employees are simultaneously members of multiple demographic categories given the example of a heterosexual Sikh or an Asian man. Now, while we may cringe at using these types of categorical descriptions, the authors report that despite the proliferation of demographic categories, neither researchers nor practitioners in management theory fully understand how additional classifications implicitly or explicitly influence our perceptions and expectations of outcomes. And I started thinking, what's going on with clinicians? Demographics as a source of bias. They walk into a clinical assessment, see a woman or female, and start making both implicit and explicit evaluation based on that. As I was reading this paper, I was also reminded of the story that was included in Carolyn Criado-Perez's brilliant book, Invisible Woman, Data Bias in a World Designed for Men, about the now fortuitous story about auditions held with the New York Philharmonic. While talented, qualified women and men were consistently auditioning for the orchestra, the percentage of women in the orchestra hovered around 6%. The concept of blind auditions was introduced, where auditions were held behind a screen. The results were so significant that the screening process continues, and today, women make up half of the New York Philharmonic. Anthony Tomasini wrote in the New York Times that blind auditions actually changed the face of the American orchestra. So clearly, not this linearly, but I did get here for this talk, at least, thinking clinical bias, based on seeing women as they walk into the clinical exam. What is the clinical exam? We have medical and nursing and allied health education, and it got me to the OSCE. So the OSCE, or the Objective Structured Clinical Exams, are an integral part of a clinical education, specifically the process of the clinical exam that's taught to medical, nursing, and allied health students. To put this in context, we need to take a step back. I was introduced to the inequities of women's heart health in my postdoctoral work, and some might say foolishly decided to return to school during my sabbatical year in 2017 to complete the clinical courses for a nurse practitioner certification, feeling that being a true clinician scientist might help me better understand the differences in presentation, treatment, and outcomes for women. Back to the OSCEs. The clinical reviews, exam reviews all of the major systems of the body following a prescribed method that includes inspection, looking at the person for signs and symptoms, palpation, percussion, and auscultation. This means that the first thing one does in the clinical exam is inspection, and every exam will start with what you see or saw as you met that person in front of you. So while our understanding and processes of what one writes down has changed over the years, I would venture to say that 98% of clinical exams reporting today begins as something about the age of the person, older, young, frail, elderly, middle-aged, an assumption about that person's presenting sex or gender, so woman, female, male, girl, boy, and they may mention visible minority status, such as South Asian, Indigenous, Black. The discussion about the appropriateness of mentioning the visible minority status is for another discussion, but there is a lot of discussion going on about that. Furthermore, I came to understand that when we make those statements, we're also starting to think about what we have learned about the health issues or the differential diagnosis based on the person that we see in front of us. Another quick story here, a demonstration of my own inherent bias. During my own OSCE exams, I was presented with an actor who described a classical myocardial infarction to me. In fact, I failed the exam because I was so inherently convinced that this middle-aged man in front of me was describing the classic signs and symptoms of an MI that I failed to examine his gastrointestinal and respiratory system, which are vital parts of the OSCE exam. So it was inferential bias or inherent bias at its finest. So back to the New York Philharmonic auditions. Given what we know about the clinical exam, my immediate response after reading about the orchestra audition was to capture the issues of female patients presenting to the ER and not being investigated for heart disease. I should run a study presenting clinicians with scenarios of patients presenting to the ER, but not including the sex of that person. We could collect the data on whether sex taking sex out of the question actually changed the assessment, thinking I am so smart. And but then I remembered one of my favorite professors saying, Colleen, you're just too myopic. Definition of myopic, lacking imagination, foresight, or intellectual insight. So maybe he did have a point. Nothing is that straightforward. Also, at that stage in my research journey, I had begun to investigate sex and gender differences associated with heart events under a relatively new branch of medical science labeled sex and gender science. Other disciplines have been doing this for years, well, decades. Okay, maybe they've always been looking at these areas. Our own research has identified that not only is sex, but gendered psychosocial factors that affect women's heart health. In fact, the two are so intricately related that we need to level the playing field about what I mean. So in exploring the biological contributions to human health, the sex matter, Teresa Wiseman and Mary Lou Pardue, who led the Committee on Understanding the Biology of Sex and Gender, defined sex as the classification of living things generally as male or female according to their reproductive organ. Gender as a person's self-representation as a male or female, or how that person is responded to by social institutions on the basis of their gender presentation. Importantly, they note that gender is shaped by environment and experience. What do we actually mean when we say every cell is sex? Well, every cell has a nucleus has an X and a Y chromosome, and most of your cells in your body do have a nucleus. Sex is therefore defined as the biological construct, often understood or misunderstood as binary, of female and male. It encompasses hormones, genes, anatomy, physiology. This is things that medical and healthcare researchers understand very well. It affects propensity for trajectories and prevalence and treatment of health conditions. There's differences in drug absorption and body composition and metabolism. Gender, on the other hand, is a social construct, and it's developed by social scientists and referenced or described based on gender identity, including women or men. There's many other terms in reference to gender identity, like gender fluid, cisgender, genderqueer, but this is not the only component that makes up the construct of gender. It also includes much more. It's linked to power and economics and social status. It's culturally specific, and it's distinct from sex. As I mentioned, there's a number of dimensions in which have been identified in order to begin to explore the associations of gender on health in particular. And we talk about gender identity, gender roles, gender relations, and institutionalized gender. This slide was based on work we did through a 5-country international consortium going forward, where we are able to identify various gendered factors that fall under these 4 categories. Now, an example. A number of years ago, I was part of the Genesis research team that looked at sex and gender variables associated with premature heart events. And we collected gender-related variables and created what we called a gender index. Higher scores represented behaviors typically ascribed to women. And this graph identifies the male scores in red and the female scores in blue. As would be expected, both males and females reported behaviors along this continuum of gendered variables. We collected more than 30 variables, including the ones highlighted in yellow above. The results were absolutely enlightening to me. On the left, you'll see that the percentage of participants who returned with a second heart event within 1 year was equal when we stratified it by sex. However, looking at the bar charts on the right, you'll note that irrespective of sex, people who scored higher on the gender index, reporting characteristics that are typically ascribed to women, were more than 4 times as likely to return with a second heart event within the first year following their myocardial infarction. I might add that one of the variables that contributed the most to this gender index was stress level at home on a scale of 1 to 10, which in these COVID times is likely to have increased exponentially for many. So there were significant differences in health outcome for women and men, and we've just started to scratch the surface. The fact is that sex and gender need to be measured, and we need to ensure that at a minimum, we're paying attention to these factors. I might add that our awareness of the predictive associations with outcomes has become even more noticeable in this COVID environment. But as we all know, it's so much more than just sex and gender. So we know sex and gender influence our risk of developing certain diseases. And while it's important to clearly distinguish between sex and gender, we also need to understand the dynamic relationship between these two. But there are also these intersectional factors like indigeneity, income, social status, supports, education, employment, ability, that all contribute to the outcome for men and women, girls and boys. We know sex and gender are associated with health outcomes, and our own research has gained some traction in helping clinicians to understand this. And I fully recognize that it would be far too simplistic to say that we know women with heart disease report high levels of stress at home, or any of the gendered variables we identified will affect their outcomes. But I really would like the clinicians to please pay attention. Enter the concept, at least to me, of intersectionality. Kamasi et al. Write that an intersectional framework is a strong approach to investigating health disparities. It can generate a better understanding of the social determinants of health, social inequality, and power structures. And an intersectional framework focuses on knowledge development by uncovering the factors influencing minority, non-dominant, and marginalized groups. I actually have a story about when we identified that the gendered factors were associated with worse outcomes. When we produced the gender praxis results, I had the opportunity to present them at an international congress. One of the factors associated with worse outcome was hours of housework a week. This was picked up around the world, and not in a good way. In fact, I remember clearly having a conversation with my daughter about how the interpretation backfired. These pictures ended up making our work seem less legitimate, and they were so sexist. No matter how much I tried to explain, like in the book, The Second Shift, the hours of housework were a reflection of everything women were already doing. It's a reflection of managing a family and a home. And while we would have to do something, some work to mechanically connect housework to the function or malfunction of a heart, for me, it wasn't a stretch to say that environment, culture, roles, resources, and opportunities for women were being reflected in their heart health. So back to intersectionality. I'm sure I could skip this slide for the majority of this group. And for those of you who are interested, there's an incredibly good TED Talk featuring Kimberly Crenshaw as a place to start. She was the first to coin the term intersectionality to explain the complex structures of inequality and racism as they relate to multiple factors such as race, gender, class, and more. In fact, the research world has embraced the concept of intersectionality. My own colleagues and friends recently published a paper discussing the contribution of intersectionality framework in building nursing knowledge, and state that the main goal is to grasp the relationship between identities, cultures, categories, instead of looking at the various sources of discrimination separately. They also note that an intersectionality framework is a well-suited approach in nursing, since it helps nurses understand ways in which social location and identities, families, communities are all affecting our health. More importantly, Kamasi et al. Note that using an intersectional framework exposes the complexities around a phenomenon and illuminates the social forces shaping those inequalities. My question is that's what's happening in women's heart health? It's a complex phenomenon with social forces that shape these inequalities. The key is to identify those social forces. And despite the proliferation of sex and gender research and the proliferation of literature on how sex and gender alter outcomes, we don't actually fully understand how additional factors over and above sex implicitly or explicitly influence our perceptions, expectations, and outcomes of that relationship between clinicians and patients. So now back to this Mosaic model that I spoke about at the beginning, which really resonated with what I was thinking. Holland et al. Report that the theoretical research and empirical research grounded in intersectionality demonstrates that individuals who share one demographic category but differ on another will have vastly different outcomes. We may share a demographic category of sex, but we have other categories that will force us to share different outcomes. Importantly, they note that prior work on intersectionality has assumed that the demographic categories are independent, which they're not. For example, female and disabled, they are not independent. And interestingly, research suggests that certain demographic categories are activated simultaneously within the brain, linking one demographic category to another, even when the categories are from discrete demographic categories. And they give the example of someone seeing an Arab person and assuming they're Muslim. Mosaic proposes that perceivers, in our case clinicians, integrate the stereotype from individual, foundational, intersectional, and associated categories and start to make cognitive choices based on the categories we choose when we meet those patients. So we pick a foundational demographic category, a category that two hypothetical individuals have in common when doing comparative analysis. An example, clinician walks in the room and notes, this is a woman. The foundational demographic category would be sex. Intersectional demographic category is a category that crosscuts this foundational category. This is the category that varies between these individuals for comparative analysis. An example in this case would be a comparison of a South Asian woman with a white woman. The intersectional demographic characters would be race. Associated demographic categories as well, and bears implicit cognitive link to the other categories. And that's the integration that can amplify or dilute the stereotypes that we have. Furthermore, Hall, Galinsky, and Phillips argue that an evaluation, and in our case, a clinical evaluation, is best conceptualized as a mosaic because no one component can fully characterize how a person is perceived. And they note that how these stereotypes, attributes that are ascribed based on social categories from various explicit and implicit categories, combine to influence our expectations, in this case, of the patient's behaviors. Because this is a woman that I'm seeing in front of me, these are the behaviors that I should see. In clinical terms, in the context of women's heart health, clinicians explicitly and implicitly categorize these demographic categories. As a result, they create a clinical expectations of the signs and symptoms of the woman sitting in front of them. And this is influenced by a deeply embedded cognitive process that is associated with learning that women's heart health is about bikini medicine. It's further exacerbated by this intersectional cultural stereotypes. For instance, I walk in the room and say, this is a woman. She looks around middle age, 46 to me. This is likely perimenopause. These symptoms that this woman is describing are likely related to perimenopause. And then it's compounded by other pre-held intersectional stereotypes I have about indigeneity or age or race. So where do we go from here? Well, using my research hat, I was thinking of using the Mosaic framework to help me understand how multiple demographic characteristics combine to bias the clinical assessment of women with heart disease. But also, and these are my very preliminary thoughts, given a picture of a woman in an ER, along with presenting signs and symptoms gathered at triage, what do you actually see? What are your first thoughts about what this person is experiencing? While I put two pictures of women up here, the more I prepared for this discussion, I realized that pictures would include men, but all would have similar signs and symptoms. If I were to adapt the Mosaic framework to using the steps outlined, step one, category selection, where the clinician uses an integrated configuration of the individuals. So I would ask them, the clinician, to identify what is the first thing they see when they look at this picture. What is the intersectional category? What are the other associated categories? Step two, I would suggest the clinician integrates the stereotype of these two categories. Dilution occurs according to this framework when the clinician classifies individuals as member of two or more demographic categories that they have inconsistent stereotypes. So they are classifying this as a young woman and it's incoherent. So this is a female that is young, so it's incoherent with having heart disease. They might also amplify based on the stereotypes. And this occurs when the clinician would use the 2 or more demographic categories to amplify something that's highly prototypical. This is a middle-aged. If I walk in and I see a middle-aged man, my assumptions are that it will be heart disease. Based on the responses to step 1 and 2, we can discover whether, do you believe that this woman at this age is behaving as the clinician thinks the woman ought to behave? There's various parts of the framework that could be identified and teased out during this step. I want to end by telling you about a woman I encountered years ago, but still wonder about today. I also wonder if she would get any different care or treatment today. During my Torch postdoctoral fellowship, I was strongly encouraged to shadow cardiologists in the CCU, which I actually loved. It was at that time that I really began to appreciate the lenses that we use to view women and men we encounter in clinical settings. One morning on rounds, we were presented with the following scenario. This was a 42-year-old woman, let's call her Faith. She went to a rural ER for chest burning, flu-like symptoms, nausea, and stating something was really wrong. My heart is racing, I can't breathe. She was sent home to follow up with her GP, suggesting it was likely anxiety. Faith was feeling much worse at home, and with her husband on nights, with 4 children less than 10 years of age, decided to wait until the morning when her husband got off nights. Her husband called an ambulance at 8 a.m. When Faith arrived at the rural ER, they forwarded her on up to Edmonton via an ambulance, saying she was having an MI, myocardial infarction. She went up to the cath lab, there was no obstructions noted, and the EC changes had resolved, which may have been due to spasm, and it was determined that there was no further treatment required. She had no traditional risk factors, and her only recent medical history included a therapeutic abortion 2 weeks previously, but clearly, quote in the notes, this had nothing to do with myocardial infarction. The medical assessment was that she should be followed up with her GP. Here's what I saw. During rounds where we were all in her room, it was day 2, Faith's husband arrived for the first time with 4 children in tow as he wanted to meet up with the doctor and was told that he'd have to come in between 7 and 8 in the morning. Faith reported that they just recently moved to their rural home and did not have any supports or friends that could watch the kids. The husband's face looked incredibly anxious to me. He was noticeably relieved when he was told that Faith could come home with him, and there was a discussion that he could work that night when they were all back home. Faith had been in the ICU one day and had arrived via ambulance. However, there were individual pictures of each of her 4 children in frames on her bedside table. When I asked her to tell me about the kids, their names and ages, she beamed. She said she loved being a mother. I did reflect at the time to myself, the decision to have an abortion is not ever taken lightly by any woman, and wondered about how difficult that decision would have been for this family that clearly loved children. What stress did that cause? And what was there a relationship between that and the issues with her heart? Faith is but one of an unacceptably high number of women who are still being intersectionally stereotyped, including the women with lived experience who are part of the Canadian Women's Heart Health Alliance, who I've come to know and care for. We are in fact biopsychosocial beings, and only addressing the bio aspect, which evidence, or in this case of women's heart health, lack of evidence suggests is sex specific, lends to not truly providing patient-centered care. But I want to finish on a more positive note and tell you what we are doing to continue moving forward. Wear Red Canada Day, proudly hosted by the Canadian Women's Heart Health Alliance, is celebrated annually across Canada on February 13th to raise awareness about women's heart health. Events are held across the country to serve as a reminder for Canadians, but especially Canadian women, to be mindful, curious, and proactive in the management of heart health and wellness. Everyone can participate on February 13th by wearing red, taking pictures, sharing them on social media, and we encourage people to share the key message on women's heart health with colleagues, families, and friends. More details can be found on Wear Red Canada website. And I do have a quick YouTube video to play that I would love to play when I was asked to talk at Research Fridays, I said it had to be in February because I really wanted to promote women's heart health as well. And there's a quick YouTube video that I would love to play, 2 minutes, if that's all right. So I'm going to end this, stop sharing. Oh, go back into this.
I think you need to keep sharing so that we can see the video.
Yeah, I'm just, okay, I was just going to pull it out and share it on. Okay, I'll try it that way. Good idea. So
whatever way you do it, you'll need to share your screen, right?
Yeah, yeah, for sure. So I'm going to go back to this, share, and see. When I've done this in class and I try and share the screen, it doesn't share it properly, but with a YouTube video, it doesn't go to that control copy. I was telling someone today, I've taught on, I'm going to stop share and I want to share this, control. Not going to. Okay.
You can
sorry.
just share this. You can just put it in your browser and then still share your screen. It just shares a different.
Yeah, that's what I was going to try and do. Okay, so share a screen, and I'm going to go into a browser. This is still sharing my. I'm sorry to be so useless on this. This is. Okay, let's skip that. Because I really
click into your browser. If you just click the link, it should open in your browser, I think, and then you can just play from the browser.
This is sharing my email, right?
Yes, it is.
Okay. I'm going to go to where Canada Day, enter. And that's not it.
There you go.
Welcome to Wear Red Canada.
I'm going to try this again.
Welcome to Wear Red Canada.
Wear Red Canada.
Wear Red Canada.
Wear Red Canada.
Hello and welcome to Wear Red Canada campaign 2022. Did you know that heart disease is on the rise and is the leading cause of death in women worldwide? Here in Canada, it is the leading cause of hospital admissions and premature death in women.
And did you know the majority of women remain unaware about their #1 killer? Cardiovascular research has lagged behind significantly, and there are no defined educational pathways for trainees or healthcare professionals to learn about the unique aspects of cardiovascular disease in women.
As a result of all of this, care for cardiovascular disease in women remains subpar.
This is why the Canadian Women's Heart Health Alliance created the awareness campaign, Wear Red Canada. Wear Red Canada is celebrated annually across Canada on February 13th to raise awareness about women's heart health.
Events are held online and across the country to serve as a reminder for everyone, but especially women, to be mindful, curious, and proactive in the management of our heart health and wellness.
Here are a few ways you can participate.
First, you can wear red like I did today and take a family photo or selfie of you in red and post it in social media using the hashtag #WearRedCanada or Her Heart Matters.
Second, you can share our 5 key messages. They talk about symptoms of heart attack for women, causes of heart disease for women, risk factors for women, and ways to reduce your risk of heart disease. View and download our key messages from our website and share them with your friends and family.
Register for our 5K event. Get active, run, walk, ski, snowshoe, or dance in your living room. You don't have to do it all at once. Track your progress towards a cumulative distance of 5 kilometers or to a time of 30 minutes of physical movement of your choice between February 13th and 28th.
Attend an event. Register for our free virtual national education program taking place on February 13th. There are also many events across Canada Find one near you by visiting our website and social media.
Light the town red. Visit some of your local landmarks and storefronts and ask for them to light their building red on February 13th in support of women's heart health. Don't forget to take pictures of buildings lit in red and share them on social media.
New this year, we have created our first Facebook group. So join us to learn about all upcoming events and be part of Her Heart Matters community.
We want you to be mindful, curious, and proactive in the management of your heart health and wellness. Because to take care of others, you need to first take care of yourself.
So join us on February 13th for Wear Red Canada. For more info, go to wearredcanada.ca.
So I want to thank you sincerely for listening to me and helping me work through this whole process as I'm trying to figure out how to move forward with intersectionality.
Well, I want to thank you. That was so incredibly interesting and important, and I learned so much. I will say, you know, as somebody whose mother died suddenly about 1.5 years ago from a heart event, I can't emphasize enough how these takeaways matter, and you know, such a complex way of so many factors that enter into this framework. And I'm so fascinated, I think, myself, and I welcome questions and comments. But while people are maybe digesting their own thoughts, I'll add a few of mine here. It's interesting to me the role that the Philharmonic study plays in your analysis here, and the way that blind auditions can function. And it seems like that's a very big challenge for a medical profession where, you know, you are physically presenting. So kind of standing behind the curtain and not being seen is not an option here. And I wonder if you have thoughts about how, or whether that's your goal somehow, to figure out ways that we could create, I guess, diagnostic conditions for a similar kind of thing to happen. Or do you think that that's actually not really what we're going for here?
I think absolutely that's what I was going for, but you've hit the nail on the head. Even with the auditions, I kept thinking, are you not going to hear the feet clicking in? You know, or do they hide the feet? Or anyways, that's not possible in our clinical environment. And so that's why I was thinking with this study is that we would show pictures and say, what's the first thing that came to your mind, and start that education to clinicians, because I am absolutely as at fault as everyone else. If I mean, that's part of human nature. You look and you see the person in front of you and you start making decisions about it. It's just that in our medical and nursing education, we start making clinical decisions based on what we see, and maybe those are wrong. And the other thing you just made me think of is, you know, we've started to say, you know, that we need to ask I want to say the gender question, but the first thing that we're just starting to think about is, say, how would you like to be identified as you walk in the room? Because that will also trigger me to say, okay, I'm already making assumptions about this person because I've asked them. But if that was our first question, how would you like to be identified? Without sounding offensive, or you know, my fear always is that word actually sets off the whole clinical assessment differently by how we word those. So,
but maybe that's not a bad thing. I mean, as you were speaking, I was thinking of a quite famous philosopher's work, Judith Butler, who published a book maybe 30, 40 years ago now called Gender Trouble. And in that, she says, when the point at which we distinguish sex from gender, one being the biological and the other being the social, one of the peculiar things that happens is that the things that we think we're separating out when we say gender versus sex, we then start to somehow still impute to gender. So it becomes binary, it becomes somehow still tacitly biological, even though we're trying to evade the biological. And I wonder then, your comment just made me think, oh, so what happens not just to the stressed mother of 4 children, but to the transgender or non-traditionally gendered persons, and what kinds of stressors do we need to think about that would be the equivalent of, say, housework and childcare and the stereotypical example you so helpfully took apart for us, but there are all these other kinds of equivalent stressors there too, which really does, I think, demonstrate the need, the urgency for an intersectional analysis.
Yeah, and actually the thing that's happening, I find a lot in the scientific or the medical literature right now is that we are equating gender with gender identity too, and I really want to get away from that. It's these other gendered factors, regardless of what sex you are or how you identified, of culture and of race and of ethnicity, that are influencing how you're getting treated.
Mm-hmm, mm-hmm. And of course, you know, one of our great insights from intersectionality is that race transforms gender, right? So it's not that if we can have these we can keep everything separate. We have the fantasy that everything is in as a discrete demographic category. But as you pointed out, when these things overlap, they're mutually transformative. And that actually kind of messes with the categories that we like to have in nice, neat columns, right?
Totally messes with it. Yes, yes.
There's a number of fascinating comments here too. I don't know if you can see the chat, but I'm just going to read through some of them just sort of bring them into the conversation. Somebody observes, Patty Castleman, I think that EMS personnel need to be included in awareness and training in this, since they're often the first ones on emergency scenes. It's not something that's really covered in the learning and development with EMS, and this is something this person knows from because their partner is in that area, and they were hoping that you might be able to kind of share your insights also with the School of Public Health, because the students there would really like to know something about that. I don't know if you have any thoughts on emergency services as opposed to, you know, the clinicians and how that they play a role here.
You know, it's whoever sees that person first, it's going to matter. And absolutely, in the literature that I've looked at as far as care of people who are having, men and women who are having heart attacks, there is this bias with the EMS when they come to a woman's home and they assume it's not a heart event, and so women are getting treated later and have more damage to their heart. There is some of that in the literature. So, you know, I'm still stuck with even for me, how do I go into a room and not start making these? How do we get the whoever is seeing clinicians? Like, I'm stuck on the ER because that's a big logjam right now, and the fact that these 300 women are going home and coming back with a heart attack is offensive to me. There's something really wrong with our system there.
Well, and I think the system problem is another one, because, you know, if people are being sent for follow-up with GPs, it assumes everybody has a GP, which we know is a challenge in Alberta, but not only in Alberta, but particularly in rural areas. And right now, you know, many doctors are leaving the province, we hear anecdotally. And I also know a story of a friend who went to the doctor a few weeks ago who had a racing heartbeat, and her GP observed that cardiologists don't like for GPs to refer too many people up because they think it means they're not doing their job or they're being hyper, you know, sensitive to things. And I just think, oh, is that really a problem of the GPs, or is that a problem that we don't have enough cardiologists?
Yeah, and honestly, our Wear Red Canada is awareness, and part of it is talking to women about how you need to. This is what's going to happen. You're going to be told this, so what do you respond? Okay, well, that might be the cardiologist. You know, there might be a problem with referral, but I would like the referral unless you can answer the questions for me with what's going on, because I don't want to go home again today from your visit and not know what's going on with me.
Mm-hmm. Mm-hmm. Exactly. There's just so many factors here in this systemic analysis, which we have another comment in the chat that says you didn't mention weight, and someone sees that as a large influence in early assessment emergencies. Do you agree on that point? Or I know this.
Yeah, absolutely. Again, it's that you walk in and you see, and so if you walk in and you see a woman who is weight challenged or is high BMI, which is the way we look at it, and it's a woman with high BMI, you start thinking diabetes, you start making these assumptions about the care, and it is important. There's no doubt.
Yeah, there's been a lot of interesting analysis, I think, on the ways that weight sometimes prevents people from seeing other kinds of events, because people assume the origin of a health problem is always in weight too, right? So it seems like these stereotypes can kind of cut in multiple ways, right?
Oh, for sure, and it is a stereotype because they, there is evidence that people can be very healthy and still have what we consider a high BMI.
Yeah, indeed. And the BMI, of course, is also a calculation based on the male model too, just the statistic itself.
Totally.
Yeah. We have a question in the Q&A to an anonymous attendee. It says, during your discussion of the Mosaic framework, you brought up amplified versus diluted stereotypes. Can you expand on that?
Oh, sorry about that. So my knowledge about it is I've been reading it to prepare for this. So the amplified is that there are, when you make assumptions about putting people into two categories, and it actually amplifies your thoughts about this is an older woman, so this is what it's going to be. And where the diluted is, I see a young woman and I'm saying, okay, well, it can't be heart disease because she's too young and she has none of the risk factors. So the fact that she's young and she's a woman is biasing me to dilute what I should be thinking about this person. Mm-hmm. But honestly, I am so, I was telling a colleague, I was so nervous about coming today because I am learning this stuff as we speak. I really am. I'm reading it and saying, oh, that applies, that applies. So I'm nowhere close to an expert on this, not even step one.
Well, it seems like we all have an enormous amount to learn, obviously, and this is why, research is really at the cutting edge of so much of what we need to kind of understand more fully, and what does intersectionality open up as a research problem for us. We have a comment here that there's a chapter in obesity BPGs on bias is worth a look at some of these same things. I think that there's a link that Terry Vaktu, sorry, I'm very apologize about mispronouncing your name, but that Terry has provided in the chat for us, so that may be another place for you to
I'll copy it for sure. Yeah,
fantastic. I mean, on this matter, this might also be a good time to announce that Intersections of Gender is partnering with WICRI, the Women's and Children's Health Research Institute, on a series that will begin on February 15th. That is a perfect segue from your talk today on intersectional health research. So we're going to begin with some overview comments with doctors Bukala Salami, Denise Spitzer, and Susanna Luman. And they're going to really talk about a kind of broad overview. So we're trying to pull more and more researchers who are in this area of Dr. Norris's specialty and to try and broaden this out so that more people will see the relevance and importance for their own work. And we hope to follow that up with some workshops on how people can share their expertise, on applying this for grant development, because really what we're doing here, and Dr. Norris is clearly a pioneer in this field, is trying to somehow expand, but it feels like it's on the edge of something, and we need to make it central to what people do. And even when they think it's not intersectional, that there are implications for so many populations in terms of this work, and not just women with heart health, but every kind of medical analysis that we have really has to kind of consider this multifactorial approach. I don't know, Colleen, if you want to say more there about how you see this research in the context of your field more generally. Do you feel like it's central to what people are doing and talking about, or are you really having to work hard to bring it into view?
From my perspective, I'm really having to work hard to bring it into view. And even in the cardiovascular literature, it is consistently, women have been underrepresented in all of the clinical trials. And I don't know if people realize when you get care for something that the clinical pathways that we use are based on the randomized clinical trials. So we go and we look at the evidence, and we look at the evidence of a drug and say it works with these people and it doesn't work with these people, and those become our clinical. But in all of those trials, women are underrepresented. So we don't really know the evidence on women. And so I'm sure very annoyingly writing to every single editor when they publish data in heart health saying, can we see the data stratified by sex, please? Could we at least see what the outcomes were for the women in the study? And the response is always, well, there weren't enough and there's not enough statistical power. And my response is, I don't care. Let's see what the trends are until we can get enough women in trials. for the statistical power. This is not unique to women's heart health. You know, aside from you know, the stuff that is completely pregnancy and stuff completely related to women's health, it's pretty rare to have enough women in the trials that you're actually saying this is what we should do for the women.
Well, and what's interesting is that that's never a sign of a failure in the trial, right? It's never a sign that the trial itself has been insufficient, right? And so if we didn't get enough people, not enough people came to us, which shifts the burden onto the respondents or potential respondents from the patient profiles and doesn't put the onus on the people running the trial actually to get better demographic categories or overlapping categories met in the trial.
Yeah. And I have a story about that too. I was shadowing at a clinic over in the rural Alberta. We have identified that, you know, preeclampsia or high blood pressure and gestational diabetes actually lead to heart disease if you don't monitor those risk factors after you've had the baby. So I was over at the ALEC. They have this incredible clinic that's offered for women who've had preeclampsia, and you sign up to be part of it, and a social worker and physiotherapist and nutritionist in order for you to control your risk factors. But they have like a 25% show up rate. And these are people that agreed to participate. And while I was there, the phone rang and it was a woman in her car, and you could hear the baby crying in the back. These are women who've just had a baby, by the way, screaming in the back seat. And she said, "I'm effing going home. I've been driving around this parking lot for 2 hours." And that made perfect sense to me, in the sense that how can we suggest that a woman could have a baby, find parking, and get into our big healthcare facilities in order to participate in this? We need to be going out to them. Like, it could be in a community center or something along those lines, right? And start thinking about how do we adapt to the women instead of the women adapting to us.
Well, and this, I think, comes to the next question that we have in our Q&A. This person says, it sounds like education is needed for both clinicians and patients. What about policy change? What else needs to change in our ERs to support women's heart health? I mean, this kind of is the extra, that's extra social space of the hospital. And what else can we change there?
Yeah, so the policy changes happen when we get the evidence to say this is what's happening. And so that's what the Canadian Women's Heart Health Alliance, this is a group of people from across Canada. They're saying this is what's happening and how do we change policy? And that's our role. And to go back and say, here's the evidence. We're not getting people in the trials. We do know this is what's going to happen. How do we adjust that? What is the policy? Like, does everyone? Right now, we're looking at whether facilities need to have a woman's heart health protocol of somehow, just even the word heart health protocol. Because when I had my mom in the emergency department, I was talking to one of the nurses there at the U of A, and she said, you know, we have a chest pain protocol. So if the woman doesn't say, I have chest pain, she doesn't get into that protocol, right? And it's followed up. So a woman will come and say, oh, I've just had this squeezing, burning in my chest area. They're not going to get into the chest pain protocol because of the wording. So it's stuff like that we actually could change, right?
And how is the patient supposed to know what the key buzzwords are in order to kind of hit the right buttons for care, because they don't have the cheat sheet?
Yeah.
And maybe this, perhaps given that we're close to time, but we do have one more interesting question from the chat. Esther Schwab says, from a legal perspective, at what point do gender assumptions about female patients become medical malpractice? I mean, that's a whole other angle on this. When are you not doing your job? Right? Yeah,
and you know, no clinician is going in there saying, I'm not going to take care of this person properly, right? We know that. And so I think the angle there is that we teach women to advocate for themselves rather than having to go back 5 and 6 times. On that first time, I mean, we've written little cards that I'm publishing for Wear Red Canada Day. They say, these are the questions you ask. Okay, could it be my heart? What test do you think I should do? Don't just send me back to the GP. What am I supposed to ask? Like, what caused me to have these pains in the first place? So we need to advocate for ourselves. Or the other thing that's really worked in the women's heart health, evident in the women's heart health literature, is bring a friend with you that can be strong.
But what I also hear you to be saying there is, we also have a responsibility as clinicians, as educators, as researchers, to create the conditions of possibility for people to advocate for themselves. And that's what I hear in this circulation of these cards. Not that it's just the individual's responsibility, but that we also give them the tools for being able to ask the right questions, which seems very different from saying it's just on them to advocate, right? This seems like a much more radical suggestion to kind of, and puts it on the system rather than the individual.
Totally. And it can't be on that individual. They've just suffered. They're worried that yeah, they're not in a position to say, stop, listen to me.
Yeah, or if you have those 4 kids and you're so worried about getting their pictures to take in the ambulance, probably you might forget something else. And so like this idea that, there's a protocol that needs to be maybe democratized is maybe the not quite the word for it, but to kind of, that is more available to people, that says, oh, here's what I have to do here, because no one practices for an emergency, right?
Yeah, exactly.
Rachel has observed that we would be very happy to have some of these to post about later on if you have these cards, so we can kind of help you through our network. And if you aren't part of our network already, please sign up for our newsletter for Intersections of Gender, and anything that we receive from Dr. Norris or any of our panelists, we're very happy to send out so that we can become part of that distribution network. I'll put another plug in for the February 15th event, which I think Rachel has put our subscription registration information in here. And I think this will be a beautiful continuity of this conversation here today. And we certainly have only started to scratch the surface about what an intersectional approach to health outcomes might be. You can see that there are thanks rolling in here in the chat for your presentation. I know that I loved it, and it seems like everybody else did too. And we are just so grateful for you to have joined us today. And I wish we just had more time to hear everything and keep going. But
I'm really grateful for the opportunity. Thank you.
Thank you. And thank you to all of our attendees for joining us today. Please come back again for the Intersectional Health Series research. And we'll also have another Research Fridays event on March 18th with a distinguished visitor from the University of Würzburg in Germany, who's going to talk to us about histories of colonialism and migration in Germany and France and their relevance for the Black Lives Matter movement and how it's developed in those countries. So lots of programming. Keep in touch with us, follow us. Wear red on February 13th. I know I will. And thank you to everybody, and especially to Dr. Norris today. Thank you all. Stay warm, stay well.
Go on wearredcanada.ca. Tons of information. Okay.
And great. And someone's asking about intersections of gender. Rachel has already put this in the chat, I think, how you can sign up for our newsletter. So I will leave the screen open for a few minutes, but I see everybody is already filing out. Thank you again. Thank you.
Nice to see you again. Take care.
All right, take care.